Hello everyone, and welcome to another edition of Overcoming Depression and Anxiety, brought to you by Healthy Me Summits. I'm Joanna Rushton, your host, and we're being joined today here by Professor Irving Kirsch. Professor Kirsch is Associate Director of the program in Placebo Studies and a lecturer in medicine at the Harvard Medical School. He has published 10 books and more than 200 scientific journal articles and book chapters on placebo effects, antidepressants, medication, hypnosis, and suggestion. His 2008 meta-analysis was covered extensively in the international media and listed by the British Psychological Society as one of the 10 most controversial psychology studies ever published. His book, The Emperor's New Drugs, Exploding the Antidepressant Myth, has been published in English, French, Italian, Japanese, Turkish, and Polish, and was shortlisted for the prestigious Mind Book of the Year award. It has been the topic of 60-minute segments on CBS and a 5-page cover story in Newsweek. Professor, thank you so much for joining us. It's been a wonderful opportunity to have you. It's an amazing subject to be able to talk about, and so absolutely fitting for the nature of our summit, Overcoming Depression and Anxiety. So,
well, thank you very much, and thank you for that kind introduction.
Oh, you're very welcome. Your work is amazing, and I think where we would love to start is to connect our audience with the type of research that you have been doing, and your research in particular, to start with, around the effectiveness of antidepressants. Could you share a little bit about what that research, what you've learned from the research that you've done in this regard?
Sure. My colleagues and I have done 3 studies on antidepressants, a kind of study called a meta-analysis, in which you take a bunch of studies that have been done, that have been reported, and you pool the results together. And I think the most explosive one was a study we did using the data that the drug companies had submitted to the FDA for the approval. In order to get approval, the FDA is the Food and Drug Administration, which is the agency that grants approval for new prescription medications in the United States. And we use a law called the Freedom of Information Act to get the FDA to send us the data that the drug companies had sent to them in the process of getting their drugs approved. And what we found was that it's true, if you give a depressed person, if you give depressed people antidepressant drugs, on the average, you do get clinically meaningful improvement, but you also get a clinically meaningful improvement on the placebo, on the sugar pill that doesn't contain any active ingredient at all. And the difference between the two, the difference in the effect of the placebo and the effect of the antidepressant drug, is very small. It's so small that it wouldn't make any difference in anybody's life. It's barely noticeable. And in fact, it's a magnitude of difference that clinicians, physicians, cannot even detect.
Wow. So what I'm hearing in that case is that this study is highly controversial. And the findings would certainly be highly controversial within psychiatry and within the writing of prescription drugs for the purpose of treating people with depression. So what are other researchers finding in that case?
Well, you're right, Joanna. It has been very controversial, and many people have went and to see if they could replicate our results. Many of them critics initially who were just skeptical. How could this be true? There have been now many, many replications, and everybody finds basically the same thing that we find. The difference in numbers are very, very small. The FDA, in fact, went and did its own meta-analysis of all of the antidepressants that it had evaluated. And again, got numbers that were virtually identical with ours. We did it on what at that time were the 6 most popular antidepressants. So our study, the results of our study, have now been replicated over and over again, and nobody finds a drug placebo difference that, taking the bulk of the studies, that is clinically significant or clinically meaningful.
So in that case, why do so many doctors think that antidepressants are effective? If that's what the research is showing us, why is there not more willingness on the doctor's behalf or the psychiatrist's behalf to actually see the validation of these studies?
Well, there are 2 reasons for that. One is the experience of the doctor. A doctor gives a patient a drug, in this case, let's say an antidepressant, sees that the patient improves and assumes that the improvement is due to the medication that the patient was given. Doctors don't give their patients placebos. Well, sometimes they do, but more often not. So they don't have a group of depressed patients to whom they've given a placebo to see whether that is getting the same result or not. That's one reason. What happens is, because of that, their personal experience confirms or seems to confirm the efficacy of the drug. The second reason is, how are doctors supposed to know what the research shows? They read medical journals. They look at meta-analyses of them. They read product labels. Now, here's one of the things that we found out in researching the efficacy of antidepressants, or the lack of efficacy as it turns out. 4 out of 10 of the clinical trials done by the pharmaceutical companies in order to get their products approved were never published. And guess what? The ones that weren't published, almost half of them that weren't published, show very little difference, even less difference than in the published studies. That meant that people doing meta-analyses, unless they went to the FDA, as we had done, had no way of knowing how small the effect really was. They only had the published literature, which still shows a small effect, but a larger one than when you put all of the studies together, when you include the unpublished data as well. That meant that prescribing physicians had no way of knowing how small the effect was. In the labels for these drugs, that's another thing that physicians depend on. The manufacturers read labels. The FDA approves the labels. The labels say, well, this drug, the efficacy of this drug was shown in 2 clinical trials. What it never mentions, what it doesn't mention, is that there were other clinical trials in which there was no effect found. So a drug company, what they need to have is at least 2 trials showing an effect. They might do 5, 6, 8, 10 studies in order to get those 2 that maybe by chance are showing an effect.
So essentially, they're only ever exposed to the metadata that gives them the evidence that essentially they're needing or wanting to see in order to prescribe, what they're educated to prescribe. And when the research that is counter evidence of the efficacy, when that research is buried and not actually brought into light and allowed to be compared with the other studies, which, as you said, are often the minority, there's almost an imbalance of the information that's being given. And so decisions are being made purely on what's being made available, which is almost research that's always going to be to the benefit of pharmaceutical companies that are looking to increase their dividends, so to speak. So,
absolutely.
So in that case, antidepressants are used for anxiety treatment as well as depression. So, are we saying in that case that they don't work, or they do work?
Well, they don't work for either. We've now looked at the data and published another meta-analysis looking at the effects of antidepressants on anxiety. and it is as small as the effects on depression. Coincidentally, at the same time, another research laboratory in Canada did the same thing. They did actually a larger meta-analysis than we did. They found the exact same thing. So now we know with independent replications again that indeed these drugs have little benefit over placebo for either anxiety or depression. People are getting better, but the improvement is not due to the chemicals in the drugs.
Wow. Okay, so in that case, it really starts to open up the question around what could possibly be alternative approaches or better approaches. So how could we better approach the treatment of depression and anxiety if it's not through antidepressants?
Well, that's part of the good news. The good news is there are many, many alternatives to the treatment of depression that have been studied and researched, many more that haven't been studied enough yet because we don't have companies with the money that are going to stand to make a profit from it. But we do have alternatives that have been studied. We know that psychotherapy produces the same short-term benefits and better long-term benefits than antidepressant drugs. We know the same is true of physical exercise. Getting involved in the physical exercise program produces benefits that are similar to those of the antidepressant drugs, and yet don't carry the side effects, don't carry the health risks. And there's evidence that the long-term outcome is better with exercise. That is, people get better and sometimes they relapse. They get depressed again. That's more likely with antidepressants than with any of the alternatives. Meditation has been shown to be a useful tool in especially mindfulness meditation in the treatment of depression. Acupuncture works as well as SSRIs in head-to-head comparisons, studies where some people were randomly given acupuncture and some people were randomly given SSRIs. There was no difference between the two.
So what about if we combined therapies? What if we combined a non-antidepressant drug with therapy with an antidepressant? Are we looking to get an even better outcome, or are we still only going to get the placebo effect, essentially?
Well, here's what has been found with that. First thing that's been found is that combining antidepressants with psychotherapy, in the short term, it doesn't do much better than just giving either one alone. So there's no benefit from combining them. There's an even more interesting study. This was a study that was done on SSRIs, the most commonly prescribed type of antidepressant, and physical exercise, and the two combined in the treatment of major depressive disorder, in the treatment of depression. So people were either given the drug, or they were put on an exercise program, or they were put on an exercise program and given the drug. After the study, the initial improvement was equal in all three groups. So no benefit for the two combined over any one alone. But here's the interesting part. When you looked at the follow-up data, what happened 10 months later? How many people who got better got depressed again? The rate of relapse in the antidepressant group was 40%, approximately. The rate of relapse in the exercise group was 8%. Now, what happens when you combine the two together? The relapse rate went up again. In other words, the antidepressant seems to have actually quadrupled the rate of relapse that you would get with exercise alone. In the long term, it made people worse than just getting an exercise program.
Wow. So what's really interesting, just before I spoke to you, I was speaking to a gentleman called Dawson Church, who he's an expert in the field of emotional freedom techniques, and which is, using tapping of meridian points. So an alternative therapy, as you just suggested, whereby tapping on various meridian points and using other therapies in conjunction with that, such as psychotherapy, and combining the two is highly effective. But the question here is that it's also quite costly. If you're going to go and, speak to or, go with a non-drug form of therapy, the cost is going to go up quite substantially to each session that you have versus a pill that you can take, which isn't going to, cost so much. And in most cases, we're seeing that they work. However, what we're saying is that it's not the chemical ingredients that's actually working. So how do we approach the fact that it's going to be such a massive cost variance? And for those that are in a place of depression, anxiety, quite often financial situations are challenging, and it's not always possible for them to go for the more expensive alternative methods.
Well, it's true that initially the cost of medications is less than the cost of psychotherapy. In the long run, psychotherapy is cheaper. And I'll tell you why. In order to not relapse, what you have to do is stay on the medication. And so you have continuing costs, monitoring the medication itself, visits with the physician for years. One of the most popular, one of the best studied treatments for depression is a treatment called cognitive behavioral therapy. Typically lasts from 15 to 20 weeks. Then the costs have come to an end. At 9 months, there have been 2 cost-benefit analyses, one done in the UK, one done in the US. At around 9 months, the 2 are equally expensive. After 9 months, having put people on drugs and keeping them on drugs is more expensive than having giving them psychotherapy. The British government was so impressed by these results that they started a training program in which they have been training 10,000 new psychotherapists to provide psychotherapy for depression through the National Health Service. That means that there's going to be a treatment alternative. There is a treatment alternative that is becoming increasingly more available at no cost at all to consumers and being done by the government because they understand that it will decrease in the long run government health costs.
Wow. Okay. So that's significant. That's significant, especially when we can look beyond the instant gratification, the instant results that we want, which, when you're in a place of depression, anxiety is natural. You want to feel good as soon as possible. And so the drug allows for that to happen. But for long term, what we're saying, long term, you have to stay on those drugs unless you are going to experience a relapse if you come off it. And so long-term costs are far more significant because I've had friends that have been on antidepressants for up to 12 to 15 years. And, that begs a question, a different question around what are the protocols in terms of weaning people off the drugs? So when a psychiatrist or somebody in the position of being able to prescribe an antidepressant puts that person on an antidepressant, is it not with the idea that it becomes a rainbow bridge to, almost filling a gap, helping that person come back into a place of, rational thought, more emotional stability, and then look to wean them off as they're able to change the other lifestyle factors that, we've been talking about through other forms of therapy? Would we not then expect that psychiatrist to start weaning that person off? Why do people end up staying on for 12 to 15 years?
Well, there are a couple of reasons for that. One is some people get weaned off and then they relapse. So then they go back on it. Some physicians, and it's not just psychiatrists prescribing antidepressants, it's general practitioners as well, may just continue to prescribe. The person continues take the medication. Sometimes a person tries to get off it without being gradually weaned, and then they have withdrawal symptoms. About 30 to 50% of patients who try to just stop taking antidepressant medication show withdrawal symptoms, just as they would from any addictive drug. Some people don't benefit. They don't experience any benefit from it. And instead of weaning them off the drug and trying some other alternatives, what very frequently happens is they're switched from one antidepressant to another, and then they're given a second drug to take with the antidepressant. And when that doesn't work, sometimes they're given a third. I've seen people being on cocktails of 4 different drugs to treat their antidepressants. Nobody knows what those drugs together will do and is doing to their brains, because that hasn't been researched. That we don't know. So people are doing this sort of willy-nilly, and the consequences can be disastrous.
Absolutely. So can the placebo effect itself, can it benefit other conditions other than that of depression, anxiety, as an example?
Oh, yes. Placebos are effective in the treatment of pain. They're effective in the treatment of Parkinson's disease, of anxiety, of a host of irritable bowel syndrome. There have been studies on many conditions that are affected by placebo, usually conditions that have a subjective component, but they can also be effective on behavioral and physical outcomes as well.
Okay, but isn't there an area here that we have to look at around ethics of a doctor who, might choose to learn more about the placebo effect and then decide to use that because they genuinely see and understand that it has a far more powerful effect than the drug itself? And if they start to take that approach, aren't they deceiving their patients by, the patient is thinking that they're taking an antidepressant, but what they're really getting is a sugar pill? How does that fit into the ethics of patient-doctor relationship?
Well, I certainly agree that physicians, healers, clinicians should not lie. They should not deceive their patients, because trust is important, and it's part of the placebo effect. And if you want to have trust, you have to earn trust, you have to maintain trust, you have to act, you have to behave in a trustworthy manner. Now, it turns out that it is not necessarily true that you have to deceive people in order to get a placebo effect. There have now been a couple of studies done in which people are given placebo pills and are told, this is a placebo. It has no active ingredient at all. We did this in a study of irritable bowel syndrome. People were brought in. They were asked if the people with suffering from irritable bowel syndrome for a novel mind-body treatment of IBS, irritable bowel syndrome. And when they came in, they were told, look, what the treatment that you're going to get involves giving you a placebo. Do you know what a placebo is? It's a pill. It has no active ingredient. It's like a sugar pill. One of the things we have learned is that placebos work in the treatment of irritable bowel syndrome, of the kind of condition that you are suffering in. We've been studying this now for some years, and we have some ideas, and we have some research that tells us part of how it works. And part of how it works involves what's called conditioning. You probably know about Pavlov and the dogs and ringing the bell and giving the food. So what's happened now, you have had a lifetime of experience taking often effective medications, taking pills that do work well, and your body has learned that that's to associate that with its own self-healing capacities. We think we can use these pills as a way of triggering that mechanism so that you can find significant symptom improvement just by taking the pill. So what we want you to do is We gave them a prescription bottle, marked on it placebo, and with the instructions to take 2 pills twice a day. Half the people were sent home with that. The other half were put on a waiting list, just given treatment as usual. We found a substantial and significant and clinically meaningful improved benefit of the placebo, even though the people knew they were on a placebo. Some of them were a little skeptical, but they were open to trying it. And so we found that, yes, you can give a placebo without deception and still get a placebo effect. Now, another group in our lab has done a pilot trial with depressed patients and has found that, you can give depressed patients, mildly depressed patients, a placebo, explain to them that it's a placebo, explain why we think it will work even though it's a placebo, and they show improvement. This was a relatively small study. There's now an editorial that has been published just recently in the Journal of the American Medical Association, calling for more extensive trials of what we call open label placebo for the treatment of depression.
So my key question here in that case, I want to get really clear. Do people have to believe in the placebo effect for it to work? Because you mentioned then that people took it, they were skeptical, they were kind of open-minded. So does that mean that they were kind of sitting on the fence of, they were open to believe it versus, totally closed to it? At what point does a placebo effect get affected by someone's belief in it working or not working?
Well, that's a wonderful question. And we have hints of answers, but none that I can't answer that question for you decisively. It is clear that believing that something will work increases the likelihood of its working. That's true for placebos. It's true for real medication, including it's true for active medications that have a real physical effect. The placebo effect can add to that, so your response to the effective treatment is going to be more effective when you believe in it than if you don't. If you know you're getting an active treatment, you're going to get more benefit from it for a lot of conditions. But we also had people in that trial who started out saying, well, how in the heck is this going to work? I'll give it a try, but I'm not really sure. And some of them showed a very nice benefit. And that, in fact, asked, well, now that the study's over, can I keep getting placebo, please?
Wow. Okay. Because it's, one of the key messages that I think has just been shared there for our audience as well is to remember that when they're deciding on any form of treatment for perhaps any form of illness, not just depression, anxiety, but it might be, cancer medication, all the different forms of treatments that are available to us for different ailments. It's really important for the patient to tune in to what they believe will work versus a treatment that won't work but is perhaps being recommended to them by their doctor or physician. But if they don't actually believe in chemotherapy, they don't believe it's the right thing, they believe for example, it's highly toxic. The research has shown that most people who die from cancer have actually died from the radiotherapy or the chemotherapy as opposed to the actual cancer itself. So are we saying there then that there is a lot of value in people really in their process of choosing what treatment they go for to really consider what they believe is going to work for them, not just to be coerced or persuaded by their practitioner or doctor or physician?
Well, there are a lot of treatments that we call now not alternative medicine, but complementary and alternative medicine that can be combined with medical treatments. There are a lot of medical treatments that work well, and I wouldn't urge people not to make use of those treatments. I am particularly concerned, however, with the antidepressants, and I'm concerned about them because the benefits over placebo are so small. You don't want to use it as a way of evoking the placebo effect because the risks are too great, not just the risk of relapse, but the increased risk of suicidal behavior and aggressive criminal behavior in young people, the increased risks of stroke and death from all causes in the elderly, the increased risk to pregnant women who take antidepressants and then have children that are born with a greater rate of autism, with physical deformalities, with pulmonary hypertension that's persistent, increased risk of type 2 diabetes with antidepressants. So now we might be in a bit of a dilemma if we didn't have any other treatment. As I've pointed out, there are a range of treatments that all seem to be about equally effective. They show a little bit better results than pill placebos. But then how do we choose? And I would suggest there should be two principles for choice. One, when treatments are equally effective, choose the ones that are safest. When they are equally safe, then choose the one that the patient prefers. I know there have been surveys of depressed people in which they are asked to choose whether they would prefer to have an antidepressant or psychotherapy. 3 out of 4 of them would choose psychotherapy.
Okay. So can I just get clear, is there a small percentage or a small window, and is it a particular type of mental health illness that antidepressants or medication does actually work in? So, you know, more severe forms of mental health, be it psychosis or bipolar or schizophrenia, are they now in a category that do require genuinely a medical chemical drug to help balance that biochemistry?
Well, I'm going to beg off on answering that question, and I'll tell you why. Because this is such a controversial area, I have been very careful to make claims only that I can substantiate through research where I know the research base very well. The questions you raise are very good ones, but I have not studied the data well enough for bipolar disorder, for psychosis, schizophrenia, and so on. I have studied the effects of drugs and alternative treatments on depression and anxiety. And so I will stick to that.
No, thank you for your honesty there. It's, you know, that's really important that you stay true to what you have got evidence-based research on. And I think that, you know, the research that you do have that is phenomenal. And when we look at our percentage rates of depression and anxiety that is experienced by the general public, our knowing and our research around the placebo effect just within these areas of depression, anxiety, and as you quite rightly say, other forms of illness is, you know, highly, highly effective. So, you know, this is why we're wanting to give this information to our audience so that they can be more impartial and more discerning around their choices when it comes to their treatment protocol. So I guess this begs a question around how can a practitioner become more effective in the placebo effect? Because
well, that
must be, you know, that must be possible given what you've said.
Yes, that's an excellent question. And indeed, one can have a placebo effect without placebos. There are two fundamental components to the placebo effect. One of them, and there may be others, but there's at least two. One of them is beliefs and expectations. We know that that can play an important role. The other is the therapeutic relationship, the relationship with the clinician. We've done a study again with irritable bowel syndrome where we used the placebo, but we had one group that was on a wait list so we could have something to compare to, and one was given a placebo by a rather neutral, matter-of-fact clinician, and the third was given placebo in the context of a warm, empathic, therapeutic relationship. Got a much better effect for that group than for the other two. The clinician is part of the placebo effect, can augment that component of even physically effective treatments by spending time with the patient. In the long run, that's going to be cheaper than because of benefit than having too short a visit. Paying attention, listening, looking at the person instead of just being busy filling out notes on a computer. I remember the best physician that I ever had as a general practitioner. Once each session, each visit, at least once, she would just touch me on the shoulder like that. That conveyed meaning. It made me feel cared for, cared about. So engendering, working on having a real, genuine therapeutic relationship with your patients and your clients is one way of enhancing the placebo component of treatment and getting better treatment outcome. And the second is having some confidence in the treatment you're doing, not going exaggerated, not like, okay, I give you this, you're going to be all better tomorrow, because then you'll have dashed expectations shattered, but helping to form and build. And that's part of what the clinicians did in our enhanced treatment placebo treatment for IBS, to help build realistic but positive expectations about the treatability and the long-term outcome of the treatment.
So do we have another question there around cost, though? And if we do, is the answer the same as you shared with us before? Because the moment we start spending more time as a clinician or a doctor with the patient, I mean, here in Australia, I think, it's like a 7 to 10 minute or 7 to 15 minute window for each appointment. If we start spending more time and, as you say, giving more time and affecting that placebo effect by the therapy and the protocol, that's going to raise healthcare costs through the roof.
Now, that's a good question. Does it? We have research on treatments for depression about that because of these cost-benefit analyses. It would be nice to do similar research on general medicine. Here's my guess, and remains to be substantiated by careful research. But here is my guess. My guess is that in the long run, spending more time, allowing physicians to spend more quality time with their patients might actually reduce costs, because there will be fewer follow-up visits and fewer referrals to specialists, because the person is getting better right off the bat with the initial treatment.
Yeah, it's a very, very valid point you make there. And again, it's looking at the treatment long term. It's looking at what can we do right now that may take a little longer, but the long-term impact is A, reducing that person's likelihood of relapse, B, increasing their likelihood of a positive response to the treatment itself. And when you have those two, you're reducing the overall costs, albeit they're more long-term versus the short-term. So
absolutely. First, is short-term costs may go up, but long-term they may go down, and they may be worth the extra benefit that patients get from more effective treatment.
Mm-hmm. Professor, I want to thank you so much for sharing this very valuable information. And I think that this is the sort of information that we're really trying to educate our audience with, because I don't think that it's made available easily enough to people in their everyday search and research of what is the best path for them to take on their own personal healing journey. So I want to just thank you so very much for contributing your time, but also your knowledge and the scientifically validated evidence that the placebo effect has shown over the years repeatedly in relationship to the effectiveness, or as we now realize, the lack of effectiveness of antidepressants. So I would love just to leave us with one question. We're asking this of all of our speakers, and I think given the subject matter, you're going to really appreciate the nature of this question. And that is, we're asking our speakers to contribute an I am statement, understanding that the power of the I am plays an incredibly powerful role in the placebo effect in the creating of our reality. When we speak to ourselves, whatever we tell ourselves, our brain believes, and it then starts this whole chemical cascade to give us an experience of what we tell ourselves. So could you share with us what an I am statement is that you've perhaps used over the years to positively affect your own life?
I am capable of doing it. I am capable of overcoming these obstacles.
Fantastic. Thank you very, very much for sharing and being so open and honest in your findings. It's been a very refreshing conversation to have, rather than always feeling like there's only a drug there to take, and the excitement that it creates in the possibility that there is another alternative to treatment of depression and anxiety other than just taking a pill is a very, very powerful and inspiring one. So thank you so very much for joining us here today and for your time and for all of your information.
Thank you.
Thank you, and look forward to connecting with you again in future summits.